My name is Efe Chantal Ghani. I'm a fourth year urology resident, and I'm going to be co-leading this or co-hosting this session with both Dr. Jamie Tenko and Dr. Katie Chung. They're going to say a quick hello, and then we're going to go through the slides that we prepared, and would love to actually get more questions from you as well. Feel free to interrupt us as we go along, or to type your questions into the chat. So our presentation for you is titled Cracking the Code, How to Shine on All Your Clerkships. So when I was a third year medical student, I had an intern. She actually was a radiology intern, but doing surgery rotation, who was kind enough to pull me aside and was like, look, the things that people are not going to tell you, that people are going to expect you to do in order to shine on your rotations. So it's almost this concept of the hidden curriculum. You know, things that people expect you to know that you will eventually know with time as you navigate the wards. But it's nice if you know up front so you can meet the expectations of those who are grading you. And as you all are very much aware, our grading system is very heavily subjective. You know, depends on how people perceive your performance. So being able to identify those expectations very early on, we hope would help set you up for success. So the first thing that I want to emphasize here is the idea of teamwork. And this, I think, for some students can be a little challenging because you might be on rotation with another medical student, and there may be the unspoken expectation that you're just to outperform the person that you're working with. So I want to first and foremost caution you against that myth. So I'm just going to go through the points that we put together, and the way we're going to do it, I believe, Jamie, we're just going to switch off who goes through the slides. So for this, I think it's important to recognize the multidisciplinary nature of medicine. And what I mean by that, medicine isn't just about the doctors providing care. You've got nurses, dietitians, nutritionists, you've got nurse practitioners, physician's assistants, and the earlier you recognize what roles those individuals play and how to draw them in, the more successful you'll be navigating this new terrain, particularly for those who are now starting the MS3 year. So in that vein, you want to know your team, and I would recommend that you try and know people's names. It's a very little thing, but it humanizes you and them, and you'd go from not being just the third year medical student to being Tommy or Sarah. And I think that just taking a second to recognize those people's names makes a world of difference. And that's true not just for the physicians you work with, again, for anyone that you interface with on a day-to-day basis. Continue with simple, unrecognized acts of kindness. They add up, and they actually are noticed. I think I've seen students who do these things when they're being observed, and when they're not being observed may not do it as well, because it's a stressful time. It feels as if you have to perform during these rotations. Everyone is judging whether you stood right side of the room or left side of the room. So it's stressful, and it can make you forget to do the things that ordinarily you would do. So just try and remember like simple things like greeting, saying hello, and waiting for a response as opposed to breezing past. Like I said, referring to people by name, I think is absolutely important. Saying thank you. So you're oftentimes, as the medical student, going to ask favors of our ancillary staff that would require them to go out of their way to assist you. It might be things like, where can I find, your resident told you to go get some supply, and you don't know where the supply room. Now you asking a nurse or some person who works at the front desk where the supply room requires them to stop what they're doing to assist you. So simple kindness like saying thank you will enable them to want to help you the next time you have a request. So please keep that in mind. And like I said, involve all members of the team. So oftentimes when you're on inpatient services, there are going to be case managers, for instance, who want to know what's going on with the patient. So I personally, as a medical student, started this practice of calling every single nurse, and I still do this, I'm a PGY4, I still do this, every single nurse for all my patients in the morning before we round to get a sense of just a quick update. How do they do overnight? That way they recognize that I think that their opinions about the patient's care is important. So if you can, and sometimes time will not permit, but if you can, engage all those ancillary care providers in your day-to-day interactions with patients. So do you want to take the next slide?
Sure thing. So we'll kind of jump into part of what your role is as the medical student. It'll depend on what service you're on and kind of what context you're in, but pre-rounding is really important. And I think it can be really challenging as a medical student when you're learning and you're trying to figure out where things are and what you're doing to take ownership of your patients. And, you know, perhaps you'll see patients with a resident or a fourth year student or something like that. But I still think that you should kind of in your head feel like this is your patient and you are responsible for knowing as much as you can for being the expert on this person. And so part of that is pre-rounding. So basically before the whole team goes and sees the patient, you kind of read up about what happened to the patient and you go see that patient in the morning. And just like if I said, you want to go talk to the nurse for each of your patients. And so sometimes things are documented really nicely in the note, so reading in the chart is useful. But I agree that having this multidisciplinary nature and really focusing on involving each person, especially the person that was most in touch with what happened to that patient overnight, is really important. You don't only have to read the consulting services notes. Reading those nursing notes can give you really important information if they got sick overnight, if their pain was uncontrolled, if they had any sort of acute event overnight that the team should know about. Those nursing notes are often where you'll see that. And then also just in, you know, actual communication with that nurse in the morning. So then of course you want to go and see the patient. I think sure, there's a lot of information that can be gathered from the chart in terms of their vitals or their medications that they took, but the best person who can tell you about how the patient is doing is the patient themselves. So physically going to see that patient and accounting for that time that will take is really, really crucial. And especially if your patient speaks a language that you don't speak fluently, accounting for time that it would take for you to call an interpreter and really speak to them in the language that they prefer is important. I think kind of just a general thing to keep in mind, and I'm sure we'll touch on it throughout the talk, is as a medical student, it can be easy to kind of pick up on the roles of the team and the attitudes of the team. And sometimes, I mean, I would hope that every physician that you work with is being respectful to all staff members and, you know, speaking to patients with a translator, but sometimes that doesn't happen. But I think you should kind of maintain that integrity within yourself and really make sure that the respect that you have with the nurse is consistent regardless of how other folks on the team talk to them, and that your goal to talk to the patient in the language that they prefer is consistent, even if you see some of the other team members not doing it. So just try to kind of maintain that personal integrity. It's an aside. And then you're still learning. So there's going to be times when things that, you know, maybe the team asks about on rounds, you didn't ask about in the patient. And so I think just all the time, just be sure that you're being honest. We expect people to be learning, and we've all been there where you forget to ask even some of the most important questions in pre-rounding. It just slips your mind and you learn about all these other things. So be honest, own up to when you didn't check something or you didn't ask that question, because things come up. And then try to be as thorough as you can when you're doing it. You're still, again, learning and trying to get the sense of what's going on. So the more that you can be systematic and meticulous in the way that you prepare each morning and the way that you go about talking to the patient in pre-rounding, I think the more consistent and efficient you'll be. And then the final task is kind of once you feel like you've really you know, mastered or gotten comfortable with pre-rounding on your own, I think always asking how you can be of service to the team is great. As the intern, anytime someone's offering to help with my list, I feel really, really grateful. But you also want to make sure that it's not, you're not helping the intern but not doing your role, because your patient care and, you know, taking ownership of that patient is the first priority. We won't be offended if you don't help with the list if you need to be taking care of your patient. But if you offer to help us and then something important for the patient kind of slips through the cracks, that's something that would be noticed a little bit more frequently. So again, just really, really do your part in taking ownership of your patient. And then as you get more comfortable, being able to help out a little bit more will come.
So let's see, I hope I haven't muted myself. Can you hear me? Okay, good. So one of the things that my advisor told me before I started my intern year was there are two types of interns, and this I think is applicable to MS3s and MS4s as well. Those who take notes and those who take notes and those who forget things. And basically what he meant by that is you're not going to remember everything. It doesn't matter how amazing your memory is, and it's okay to have notes. I've seen students who want to demonstrate that they remember all the salient points, and we appreciate that you do, but it's not considered a weakness. There's no shame in having notes. If anything, it shows that you recognize the importance of those details, and so you thought to put them down. And you don't, if you want, you can recite things off the top of your head without referring to them, but having it available in case you forget something, I think speaks more to your recognition of its importance than not having it at all. So just something to keep in mind. All
Hey
right.
guys, if I could actually also chime in here. Hey guys, I kind of slipped in towards the end there. My name is Dr. Gombiade. I work as attending in the emergency department at UCLA's hospital and some of the other ones here. With regards to the notes, never be ashamed to take notes. As an attending, there's a lot more patients that I have to be in charge of, and I still take notes just because it's details that you want to be aware of. So just don't be embarrassed by doing that.
Thank you. All right, so now you've pre-rounded and it's time.
Hey, Chantal, sorry, can I pop in really quick?
Yes, please, go ahead.
I had a private question that I thought was really helpful to clarify for some folks. So someone asked me, what do you mean by the list? And so I think it's worth kind of clarifying. Usually the responsibility of a clerkship student or even a sub-I is you are assigned to one patient on the service. And so your job is to really take ownership of that person, really get to know them really well, know their history, know what their treatment plan is, and know what kind of to expect for them, and be that point of contact for that person. But there are also other patients on your service, whether it's internal medicine or surgery or what have you. And so after you've kind of gotten things tucked with your patient, all the, things that you have to do for them are done, then you can offer to help the intern with daily tasks for other patients. And that can be very helpful, but know that following your patient is the priority for you as a learner.
Perfect. Thanks so much for clarifying that. So now you've pre-rounded, and what we mean by that is you've checked in your assigned patient, and the team is coming together and they're going to be rounding on all the patients that are on the service. So that's what we mean here by rounding. So some very basic things that most people would be aware of. You want to be ready and you want to be on time. Oftentimes no one's going to wait for you to come in. So if there's, for whatever reason, life happens, there might be an emergency, you might not be able to be there in time, just try and communicate that. You can send an email to the person who's immediately superior to you. So that typically is the intern and the chief, just so that you have 2 points of contact to let them know, hey, stuck in traffic, car broke down, whatever it is, so that they're aware that you won't be able to make it in time. And if anything, I would argue to try and be there a little before you're expected, just so that you're prepared. So this is something that for the surgical services, I think is particularly useful. Oftentimes when we round, you might need a few supplies to help with patient care during rounds. It might be little things like gauze and empty syringes for us in urology. Anytime someone has a 10 cc syringe or a Foley cap, they're the most amazing person in the world. So I would recommend, instead of asking during rounds, oh, what would you need? The day prior, when we're rounding in the evening, things have slowed down, all the cases are done, or for medicine, once everything is tucked in with your patient, you're getting ready to sign out, ask your intern, what kinds of supplies would we need tomorrow morning? You can grab a few of them, stash them away so that you're ready in the morning. It's one less thing for you to think about in the morning. And then I think this we kind of alluded to. So you will receive a list of all the patients on the service. During rounds, I recommend thinking about all these patients as your patient too. And so writing down all the details that you see the intern scribbling away, write those details down and write what the plans are. You may or may not be involved, but it gives you the opportunity to step in to assist if you were to so choose. And we'll talk about that in a little bit. I'd like to think of the medical students, and actually every physician should be this, but think of yourselves as the advocate of the patient when you go in for rounds, particularly the advocate for the patient's comfort, the advocate for the patient's modesty. So with things like when you get in, especially with big teams, people like walk in, they forget to turn on the light, then someone has to backtrack and go turn on the light. So simple things like being the one who's cognizant that usually the light switch is by the door. So you want to let the patient know that the light's going to go on. Particularly for our service, we run at 6 in the morning. No one appreciates a harsh light at 6. So there's usually a dimmer light that you can turn on. And I would always say something like about to turn on the light to give them a heads up that it's about to happen. So I used to ask, do you want the lights on? But one of my attendings stopped me from asking that, because if they said no, then you're in a bit of a pickle, because you kind of need to see for your exam. So you give them a heads up the light is going to come on. And then this is a big one. I see students, particularly on services that require a physical exam, which is most of them. When you go into the room, I would suggest grab a pair of gloves, put them on for yourself, and then grab a pair of gloves for the person leading the encounter. And the reason why I say you should get ready and put yours on is no one's going to wait for you to help. So you want to anticipate the next move of the team. You want to anticipate what can be of service for the betterment of your patient, right? So if that's going to involve a physical exam and your gloves are on, and so usually what happens is the person leading the encounter starts talking to the patient. You stand across from them, not on the same side. So I see that happen all the time. You stand on the same side, you're really not in a position to assist. But if you stand on the other side, now you can help with moving the patient's bed cover down, protecting their modesty. And that's what I mean by you being the advocate. So in urology, for instance, we do a lot of genitalia exams, but we don't need to do genitalia exams for every patient. So be the person who's like, okay, the covering is not going any lower than this, because it doesn't need to. And if you're standing on the other side, you're actually better equipped to do that. And then once the exam is over, putting the covering back over the patient's abdomen. That's something that unfortunately sometimes people forget to do, and you can be the advocate for that. And before we leave the room, this is actually one of my big pet peeves. We've turned on the light, we've disturbed them at 6 in the morning, and then, we're thinking about plans for the patient, so we all walk out. Now, if this is a patient who is in pain, is bedridden, they have to wait for someone to come turn off the light. So it takes 2 seconds, light on or light off. That's it, and you can turn it off on your way out, or leave it on if they decide they want to read at 6 in the morning. So those are things that I would recommend you just thinking about as you, start to carve out your journey as, budding practitioner.
And also, just to give some highlights of my MS3 days, which is a while ago now. But everything Chantel was saying is correct. Things I'd also like to emphasize is I remember they said in the past, the med students with the largest pockets are usually the best ones that could fit as many things in there, especially for the surgical services. But also being a patient advocate, I would say, is extremely important. Just one of the things I remember from way back in the day on even my surgery rotation, where let's be honest, as a medical student, you may not necessarily know everything at all times. You're still a medical student, you're still learning. But if you take care of your patients extremely well, the patients will remember you, and the patients will ask for you, and your team will remember your patients ask for you. I still remember, I think once there was an evaluation that I had in which I think I did okay on the rotation, but I was given an even better grade because the patient was always asking where I was after I left the rotation. So just things to remember. It's about the patient at the end of the day. So.
Yeah. All right.
Just one other thing I'd add in terms of turning off the lights or things like that. Oftentimes, especially if you have a whole team coming in to do an exam, if you're inpatient, oftentimes we'll move the patient's table, which can have their water or their phone or whatever it is, or we'll knock down their little button to call their nurse. So just make sure that you kind of put things back where they were. Oftentimes patients will advocate for themselves, but sometimes they won't. And so as a student, you can be really on top of that.
Yeah, and it's definitely noticed and appreciated by the patient, and sometimes noticed by the residents, but ultimately we're all there for the patient. So even if it's not noticed by those higher up than you, you at least know that you advocated. I think that's important. All right, do you want to take the slide?
So presenting on rounds. I think just kind of even at the start of the rotation before you're on that day, perhaps you'll get to kind of observe people present, but I think touching base with especially your intern and finding out, what are the expectations for presentations? How do you guys like to present? And then getting some tips is really useful. And I think in an ideal world, we'd be able to have, patients appropriate for each student to present, and people would remember. And it can be kind of frustrating. I've certainly had times where I've gone home and presented a presentation or prepared to present a patient, and just the workflow doesn't happen. And so it doesn't happen. So always kind of ask and see if it would be appropriate for you to do your presentation. Ask if there's a specific time of day that you should go over things with your residents, and just keep it kind of in their minds that you're interested in presenting and you're excited to learn, and people will be more likely to kind of remember and advocate for you as well. And I think also just in general, just recognizing that sometimes the workflow is really, really challenging. And so if someone says, oh, this patient might not be a great one for you to present, or we're, rushing through rounds today, try not to take that too personally, and just continue to advocate for yourself and let it be known that you're, eager to present and ready to present. So kind of similar to kind of talking through what's going on, you can also look for a template. You can look at prior notes and just general kind of templates. Getting sign up from the prior students who were on the rotation before you can also be really helpful, just to make sure that the things that you're focusing on when you're pre-rounding and when you're presenting are the things that that specialty really cares about. And if there was ever any sort of mention of you potentially presenting a patient, just be really prepared to do that on the next day, because you never want to be in the situation where, we've talked about you presenting and, things come up and you forget. Similar to taking notes, I think the more systematic you can be as a student, the better. Take your time. I certainly, especially as a student and even now as an intern, sometimes you get a little flustered and you start to speak really fast. Take your breaths, take some time, and just be really systematic and meticulous about how you present, and understand that, everyone's there to listen to you, and you have the floor to do the presentation at the speed and the rate that you're willing to do. Okay. And then I think it can be really, really hard in the hospital to get feedback, especially down the line. And so as much as you can be kind of mindful of, dips in the flow of the day, ask for feedback that day or immediately after rounds, and just try to kind of learn about adjustments that you can make, and little things that you can do. And then I think another really easy way to shine on your rotations is just if there's something interesting about your patient, or some kind of new diagnosis or anything about the patient, if you just make one little comment of like, oh, I was reading about this last night, that shows that you're engaged in the learning, that you're going beyond the expected duties and really thinking about the management of that patient. And it really stands out to residents and attendings that you're kind of eager to get even more out of that patient encounter. And I'm trying to think, I had one other thought that now I'm forgetting. Oh, the other thing that I would say, just in terms of being systematic, oftentimes on rounds, you'll hear your residents say, vital signs stable overnight or no acute events overnight, but especially as a student, and again, for me as an intern, really prove that you know what stable means and that within normal limits, what that means. So give ranges. If you're saying their vitals, you can say their Tmax, or their maximum temperature, was this, their systolic blood pressures were from this to this, their heart rate was this to this. Once people start to see that you understand that, and you can still provide an assessment, you can say heart rate was within normal limits in this range, then you can kind of get a little bit more relaxed about it and just give your assessment once the team understands that you know what those vital ranges are.
Yeah, and just one quick note to that point is, it's almost a question of trust, right? They need to trust your assessment or your ability to adequately assess. And so over time, once they recognize that you have that knowledge base, they're more likely to take your word for it if you give them an assessment as opposed to giving them objective data. Any questions that have popped up, or any other comments before we move to the next slide?
Just another comment myself. I think one of the things that also happened during third year often, I think Jamie, you're referring to, is specifically with presentations, giving a presentation about a certain, let's say, disease process with your patient as well. Oftentimes, as a medical student, you're on the rotation with other medical students, and I've always found it great, especially if you're both working to impress the attendings and residents and everything as well. And navigating how you do that is also important. So if you're thinking about, let's say, giving a presentation about your patient, make sure that your medical student colleague is also aware you're doing this, so they can bring it up or find something else to do with their patient as well. At the end of the day, you can both do well in a rotation. It's usually, I didn't go to medical school at UCLA, but usually attendings are okay in terms of when both people try to impress them in that regard. So try to make sure you work together with that in that regard too.
And it shows that you're a team player if there seems to be some synergy with regard to what you're doing as opposed to everyone working there in silos. So it speaks to your character. All right, so now you've presented, you rounded, you presented, and what do we do the rest of the day, or how can you be of service? So I oftentimes tell mentees not to ask the question, what can I help with? It seems like a great question to ask, right? You want to be of assistance. But if you remember previously, I'd mentioned when you're going through rounds, as everyone takes notes on what's happening with the patient and the proposed plans, you also have a list, you also get to take notes, and then you're able to figure out what tasks you are willing to do, what tasks you're able to do, and what tasks you want to learn. Because if you imagine your intern has 30 patients they're taking care of, and now you ask them what they can help with. Now you leave them in a position where they're like, well, they think that's scut work. Are they able to do this thing I'm asking them to do? Do I have to go supervise them? They may not know what your comfort level, your knowledge base is. So you can help them by picking specific things that you're willing and able to do. So I'm going to call neurology for Mr. Jones. So you pick a task that you're able to do, you complete the task, and you circle back so that the person who would ordinarily have been doing that work doesn't have to, chase you to find out whether it got done. Then you're giving them like double responsibility essentially. So that shows that you're, able to pick up a task, there's completion, and I think that really is helpful. And then the second thing is there are things that you don't know how to do because you're in med school and you're here to learn how to do those things. So in the surgical services, there are lots of little procedures we do at bedside, or removing catheters or drains. So you can say, I don't know how to take out drains, but may I come with you when you're taking out Mr. Jones's drain? You go with them, you see them do it once, you go with them for another patient, you see them, they watch you do it, and then they can say next week, hey, do you want to go take out the drain in, Mr. Tom's room? And now they know that you're capable because they've seen your graduated progress. So I think that shows that you're taking initiative, you're interested, and that you're paying attention being around. So it sort of helps you check a lot of boxes if you approach it that way, as opposed to putting the responsibility on your team to figure out what you can and can't do. So I think I pretty much went through all these. Yeah. So any questions about that before we move to the next slide? All right.
Okay, so talking about the operating rooms. On surgical services, you'll have the opportunity to go back to the OR. And I think something that I always try to keep in mind as a medical student is that it really is a privilege to be able to be a part of someone's surgery. And I think the more that you can kind of view it as that in preparation, the more success you'll find once you're in the operating room. And so part of, understanding the privilege of being part of something as involved and invasive as a surgery is understanding who you're operating on. And so I think really making it a point to meet that person before you're in the operating room and they're under anesthesia or preparing to be under anesthesia, being that friendly face that they met before they rolled back to the OR. Sorry, rolled back is another jargony term, but moved back to the OR from like the preoperative area. I think that then you can be really, really comforting to that patient, especially during some of the prep that maybe as a medical student you can't do quite as much with. If you can be an advocate for your patient and again, be mindful of their comfort and their privacy and have them have met you beforehand, I think that would really set you up well. I also think just in general, kind of things to go through in your mind when you're preparing to go back to a case. So meeting the patient, asking about whether or not it's appropriate for you to scrub. I mean, in an ideal world, you can scrub for everything, but sometimes that's just not possible, especially with COVID. Sometimes that's also not possible. So asking if it's a case that you might be able to scrub in for, and then asking for the glove sizes for your seniors and or your intern, and then getting your own glove sizes. Then once you do go back to the OR, again, recognizing that this is a multidisciplinary team. It's one of my favorite parts about being in the OR is how multidisciplinary it is and how much you can learn from each person in that room. Really keeping that in mind and making a point to introduce yourself, write your name on the board and your role so that they can document it in the patient's chart. Kind of take that time to learn names, put a face to who you are, and again, demonstrate that you understand the privilege that it is to be in that case. I think will set you up really, really well. Some things that you can do before and after the surgery are help with the patient's positioning. So always be sure that you're wearing gloves, be really, really mindful of what areas are sterile and what areas are not. And you can ask questions. I think people are going to be very grateful that you're, thinking about those things and asking questions, even if you might feel like it's a little silly to ask if you can touch this or touch that. Recognizing that there are areas that you don't want to touch, I think will be appreciated by everyone in the operating room. And so then, again, kind of helping with the patient's positioning, and you can kind of follow along with the scrub nurses and the scrub techs to learn how to appropriately position the patient in a way that's safe and respectful and appropriate for whatever case that you're doing. There's opportunities for learning at every single level. I have also heard you just want to be really, really careful about not presuming that you'll have an opportunity to do something. I've heard stories about students, rushing to put in a Foley on a patient when that's typically not a role for that person. So just asking what roles you can do and what you can be helpful with, I think is the safest way. And again, asking those questions and demonstrating that curiosity will lead, I think, to more opportunities for you to get involved. And it's, again, similar to kind of knowing who the patient is, and meeting them, you want to know their history. Why are they having this surgery? What medical comorbidities do they have? What was part of their workup that led to them being on the operating table? Really taking the time to review that patient's chart before you go into the operating room is important. And in fact, you'll sometimes see attendings, and if you aren't familiar with that patient, then they don't feel comfortable with you operating on them. So taking the time to prepare, and then similarly understanding the anatomy of the case and what you're going to be doing. You don't have to know every step of the surgery. That's not appropriate for an MS3. We don't expect that. But kind of understanding anatomy and like understanding kind of in general where we'll be and what we'll be doing is useful. Something that I always liked to do, just because, again, it demonstrates that you're thinking about it and you're preparing, is I would try to come up with one question for each case, at least before I would go to the operating room. It can be something about, like, why we chose a certain method of surgery, or something about their clinical history, but something that is kind of going beyond just learning what's happening in front of you and really asking a question about choices in management. I think a caveat to that is that you want to be really, really careful about when you ask your question. If something is acutely happening in the operating room, or people are very focused on what they're doing at that time, of course, that's not a time to ask a kind of broader question. But if you're kind of towards the end of the case, or it's in a period of downtime where we're getting materials or supplies or something like that, then kind of read the room and then feel free to ask your question. Yeah, I think that's kind of everything. I would also, you'll see people using the operating room computer, but it can be more urgent for other folks to be on the computer. So just trying to avoid doing any sort of chart checking or work within the operating room as best as you can.
Yeah, so these oftentimes are just most two computers that the circulating nurse or the resident or the attending have access to, and the anesthesia has this at the back. So I would avoid using that, just because, the residents are trying to catch up on notes for patients. They might get consults. The attending might have patients in clinic they want to check on. The scrub tech has to put times for everything that's happening, so they need to be in the computer. And if unfortunately no one tells you that they don't want you to be on the computer, you may be on and think that everything is all fine, but I've definitely seen multiple occasions where that's come up about a student and no one told the student that that was, impeding their workflow. So just be mindful. So I think that we were actually supposed to end at 2:10. We only have 2 more slides. Hopefully we'll be able to get through those fairly quickly and so we can get some questions. But this is navigating clinic. So, if I put here urology because I'm a urology resident, but if you're going to see a patient in clinic, there are certain clinic settings that they allow you to see patients on your own, which gives you autonomy and it's wonderful. But you have to figure out how to efficiently look through the patient's history as quickly as possible, but efficiently, like I mentioned, in order to get enough information to move that patient's care along. And unfortunately, if they don't have another appointment for another year or 6 months, a year, 2 years, you really want to make sure you're doing this well. So I would recommend things like looking at that specialty clinic's last few notes, not just the last one, because it's very much dependent on the person who wrote it. So for instance, you're probably going to write the note for that patient in that encounter. If you weren't thorough, then everything that had been captured in prior notes might, fall on the wayside. So read 1 or 2. I usually read 3 notes back. And then I also always read the primary care physician's note because they have a bird's eye view on the patient's care, get a sense of what else is going on with the patient. And all of this I do before I see the patient so that I can ask follow-up questions about what has been mentioned. If the patient is seeing any specialists, I would always take a look at that just to get a sense again of what's going on with the patient. When you're looking through information, think about how you usually present a patient or how you usually write a note. So you want to make sure that you're being systematic, pick a system and go with it. So you want to make sure you're looking at vitals. If they had vitals collected, then you want to make sure that you're looking at labs, at imaging, medication lists, past medical history, whatever it is that is your order, stick with it and then make sure that you go through everything. With clinic presentations, they're a little different than being on the wards. So just check in with your residents to see how they like to present. But oftentimes, Sint is much better than verbose. And then you want to make sure that it's okay for you to do the physical exam on your own. There's certain services where they want you to do it with a resident. They might want you to do it with attending. They might want you to do it, come report, and then they do it with you. So just ask your residents what the expectation is, because again, it's one of those things that no one might tell you, and then they might evaluate you based on what you did. And then the last slide we have here is on feedback. You want to take that?
I think we're going to talk about navigating the ER really quickly.
I'm going to take 30 seconds to talk about this really quick because we don't have that much time. Everything that was said before applies to the ER. The main difference is that everything is moving much, much quicker, much, much faster. I think in all of these services, it's best to be able to have conversation with your resident and or your attending about expectations. With regards to kind of presenting in the ER, I think what's most important besides everything you talk about, everything is focused on one of the patients currently there. Everything in their past history is important in past surgical history because it can help you further focus in on your differential. But in terms of course, the history, the physical exam, the social history, and all those other things, you want to have that more targeted to why the patient is here and what things are relevant. And in terms of, let's say, your differential, which is going to be pretty important in the ER, just think about what you think is most likely based on the information you have, but also including other things that are likely. They may not be as likely, but always starting off with what you think is most likely. Whether or not you're right doesn't really matter because you're still a student. We just like to think about your thinking process and why you think something is a certain way. And the last thing I'll say, of course, this advice session can be much, much longer, is always be nice to your nurses. They can always help you think about it. The nurses always have, especially the ER nurses, have a lot of experience with things clinically. So also get input from them about certain things with their patient as well. Okay, I'm good.
I just wanted to add a couple things. Something that talking about nurses that reminded me, I think a pet peeve of a lot of folks is when med students call the nurses and say, the team wants you to do this. They often know the team better than you do. So you can just say like, hey, I was asked to do this, or for this patient, like, what do you think about this? Like, I think presenting it as the team wants you to do this in this kind of like declarative way doesn't tend to go very well. You can try to be a bit more personable. And I think that's kind of a finessing that people find out kind of along the way. And then one other thing, I had a great question actually for the residents and attending on this call is, what resources did you find to be really high yield during your clerkship year to help you shine?
So it really depends on the rotation in terms of resources. Someone already put here in the chat, I always spoke with the medical students who had just finished the rotation to get a sense of the likes and dislikes of the attendings, the nurses, the residents. So I would fall in line with what they wanted. And then the resources might also change with time. I think when I was a med student, there was this pocket medicine that we used. I don't know if people still use that. And then for surgery, gosh, I'm forgetting the names of the books, but they change with time. So I would defer to people who've most recently done these rotations because they would know what people tend to go back to. I know if you guys are closer to MS3 years, any thoughts?
Yeah, I have no idea. I'm too far away from MS3 years, so.
I remember that my med school had some sort of surviving MS3 iBook, and it had some tips and tricks and some resources. I'm forgetting what they are now, but I can try to send out, or I can put my email or something like that and try to send it out. But essentially, again, it's going off of the expertise of prior years, and I think that changes over time. And then the other thing is there's all these different, I think there's one that's like Step Up to Medicine or something like that, or case reports or case files. There's different types of resources in terms of your studying that's less for actual like day-to-day work, but for studying. And I think you'll kind of figure out what you're drawn to, whether you like reading about diseases and then applying that knowledge if you're doing UWorld or something like that, or like more question-based learning to begin with. And so once you're doing that, I think that's helpful. And just like Katie wrote in the chat right now, anytime you're in the hospital, up to date what's going on with your patients, and try to do that active learning while you're working. I think oftentimes, especially in your third year, it can feel really, really stressful that you're staying late in the hospital or coming early and you're not having time to study like you did in your first 2 years. But try to remember how much learning there is on the wards, in the clinic, in the ER. You'll go to do your exams or something and you'll remember that patient and think about your workup and it'll click with you. But I think also active learning with up to date can be super, super helpful.
Lovely. Does anyone want to take the last slide?
You should close it out.
Okay. So we'll try and be super quick here, but feedback is so important. You want to know what the expectations are. If you're meeting them, you want to give yourself enough time to correct any deficiencies if they are identified, or any weaknesses that are identified, and be open to doing some introspection to see if there's truth behind the feedback. Because sometimes people hear something that they didn't expect and then immediately get defensive and don't allow themselves the opportunity to grow, and you can't grow if nothing is changing. So I would say to try and get feedback, I usually do it personally like 1/3 of the way in, give myself time to get to know how they work and for them to get to know how I work. I don't wait to the halfway point because I personally feel like it might not be enough time, but some people do. So at the beginning, you want us to find out what the expectations are of the seniors of the team as well as the attending. Can you hear me? No, pause for a second. And then you get feedback at, I would say, 1/3 to halfway through the way. And then you want to make sure that you have some time to make the appropriate changes. I usually ask about feedback in writing so I can give them some lead time for them to think about it. So it's not just like, oh, everything is great and nothing that is actually substantive. And then you want to make sure that you have something to share as well, because you don't want to be sitting there and it's like an awkward silence. They usually will ask you things like, how do you think you're doing? What are your strengths and what do you think you could have done differently? So just have some quick answers for those kinds of questions. So here I have here what you have learned, what you think you did well, how you think you could have improved, because that also helps you kind of dictate your narrative a little bit when you tell them these things. Because you don't want to you don't want them to notice deficiencies they hadn't noticed, first of all. And you want to also show them that you have the introspection to be aware of what those deficiencies are, and you've already come up with a plan as to how to fix it. I noticed that I'm having some issues with tying knots. I took a bunch of sutures and I have been practicing X number of times, so they know, okay, you're proactive about wanting to improve. And then you want to give them some feedback about the rotation, because other students are going to come after you and help pave the way for a better experience for them as well. Because they also are, their jobs is to train anyone, to give them the opportunity for them to improve too. So with that, I hope this was helpful for you. Oh, there we go. Do you want to share that?
Sorry, what was that?
Oh, did you want to share what you typed in?
Yeah, of course. There's a question asked about what you can do in terms of, let's say, reading the day before in an EM rotation, but that's kind of impossible because the point of EM is anything can happen at any time. Most people do emergency medicine during their 4th year. So there's some schools that do it during their 3rd year. The thing is that with emergency medicine, because you have such a wide breadth of knowledge you have to know, there's nothing wrong with reading on shift. So there are different books. I think one's made by EMRA. That's like a summary of the most common things in emergency medicine that you can see. If there's certain things, I mean, I think after your 3rd year, you have a certain idea of what could be there. And then you can read these books that give you the, let's say, the physical exam signs, vital signs, and other things you'd expect for a certain disease pathology, and then it will give you a recommendation of management. I think that's a good way to think about it if you don't necessarily already know certain things, but it's really hard to kind of read beforehand. You can continue reading in general for EM, but reading the day before, you don't know because you don't know what's going to come in.
Regarding EMRA, this is what it looks like. I don't know if you guys can see the screen.
Thanks for the assist, Katie.
It's this like little tiny pocketbook. It's like so good, you guys.
Lovely. And Liddy, do you want to take the question about multiple students in the operating room?
Oh, sorry. Can you repeat the question?
So the question asked, are multiple students in the same surgical rotation, on the same surgical rotation in the OR simultaneously? If so, how does that change your role?
I think, I don't know, it's kind of hard being on the anesthesia end because we only get one student at a time. But I think just observing on the other side is always nice. I think it's always nice just to like get feedback from like your co-medical students. Like they were mentioning earlier, always like assign tasks to each other. Like, oh, do you want me to take more of the duties during this session? And then, you know, it's always going to be a follow-up surgery. And then you could do more of the stuff for the next surgery, and make sure your residents know. That way it doesn't look like, oh, why is he doing all the work and she's not doing anything at all? So I think communication is always key. And like they were mentioning earlier, when you're either pre-rounding or in anesthesia, we do pre-ops with our attendings the day before. And we do it with the med students also. But I think if you do them for general surgeries during like pre-rounding sessions, always like get set in line what the duties will be during the day. Like we were mentioning earlier, like ask expectations of me. And, you know, like we were mentioning also earlier, not saying like, oh, what else do you need help with? It's more like, okay, I completed this, and that. I remember for this patient, you mentioned this. Do you want me to do anything else for them? Preface it with something like that you already did, not necessarily, because that's always the go-to, like, oh, I want to go home now. Is there anything else you need me to do before I could get home? So people know that those keywords. So definitely go about it in a more natural way. Like, you know, you're there to learn. You only have so much time, and it is very tiring. Obviously, this is a lot of information. I was definitely one of the slowest people in my medical school. And so if you need to take a longer time, you know, to stay in the hospital, like preview all your patients for the next day, take that time. You know, some people will be like, I don't know why she takes so much time. Like it's quickly, like don't think about it too much. Well, for me, you know, things don't come as easily. So I need to take that extra time and, you know, take advantage of like these sessions when people give you a lot of feedback. Because trust me, so many times we give our email, we give our phone number, and then people just never follow up. And we're not at loss by any means. But I think for you guys have great resources from us as residents, that we're already in the game and we know how things play out and we know how we struggled as medical students. So we have a different outlook on looking back on how everything played out and looking forward, seeing how med students interact now. So take advantage of us as resources. You know, if you're going to an SNMA or LMSA session and they're talking about rotations, but you're not in that rotation, yeah, you know, follow up with them when you do get to that rotation, because that's super helpful. Because I know so many times I was like, oh, I remember I went to a session on like peds when I was interested in peds and I can't remember what they told me, et cetera, things like that. And, you know, once you make that connection with somebody later down the line, if you need anything or you think they could be a resource, definitely reach out. They gave you a number for a reason, so don't be afraid to send them an email and a follow-up email if they forget to reply.
Yeah, the worst that will happen if you send an email is they don't respond or they say no to a re-asking, but yeah, just move on.
Mm-hmm.
Any other questions?
The only other thing I'd add in terms of feedback is that I think one thing that it can be really hard third year because you can hit your stride on a rotation and then you switch and it's a new team and the roles are different and you feel like you mastered doing this finally in your last week or something, and then you switch again. So I think, like, to the point of asking for feedback early, that also offers you the opportunity to say, you know, on my prior rotation, I actually had the opportunity to call a consult for some of my patients. Does that seem like something that I could do? Or advocate for yourself and the other things that you want to get out of the rotation. And it offers opportunities for you to like get more feedback on the skills that you're trying to build and stay consistent throughout your rotations, even as the teams are switching, even as the service is switching and the clerkship is switching. Try to find the things that you personally want to work on. And I think it offers an opportunity for you to kind of advocate for more responsibility or roles as you see fit. And it hopefully allows you to get something more out of it.
I think one thing that I have seen some med students do, or I've encouraged med students to do that I really appreciate personally, is when you come in with a goal in mind, because I think eliciting feedback in a kind of blanket way, we're, you know, tempted to give you general feedback that's not helpful to you. So if you say like, hey, my goal for this week is to really nail, you know, differential diagnosis in the like post-op period, or like something really specific. And then that gives us a cue to like think about that when you're presenting and give you direct feedback on that. Or like, my goal is to work on, you know, presenting a good subjective or whatever. Having some kind of goal that you can elicit feedback from specifically, I think will help you hone more specific skills rather than just saying, hey, can I get feedback later? And I think it's okay to take that initiative to guide your own feedback as well.
One other thing I actually want to share. I'm gonna be honest with people. Third year, for some people, it's amazing. It's like the best time of their life. I think for most others, it's good, but there's some parts that really suck. And the reason why I say that is because the thing that's difficult about third year, for all of us who are in medical, who went through medical school, you know, you're used to doing well on exams and various other things. And for many different reasons, you're used to controlling your ability to do well on an exam. And third year comes into the mix, and you have a combination, of course, the shelf in addition to the subjective evaluation. The advice we give you here are things that should be able to help you. If you do this, you stick to it, it'll help in most cases. There are times, unfortunately, where because of the subjectivity of third year, you may not necessarily do well on an evaluation because of team dynamics or certain things that may be out of your own control, regardless of how good you do, regardless of how much of this advice you follow. The one thing I always still emphasize to students is try to study as hard as you can also for your shelf, because it is the one part of your grade that you can, as much as you can, control. And sometimes when you are on the borderline because a certain, let's say, preceptor didn't give you as great of a evaluation, your shelf can sometimes save you. Not to say only focus on the shelf. Third year is not about the shelf, but just don't let that fall by the wayside because of the subjectivity of third year, the shelf can sometimes save you. Just be aware of that.
There's one other thing I wanted to say with regards to transitioning teams. So we mentioned that you as a medical student, you know, you transition from rotation to rotation, but sometimes you're caught in the middle where the residents are transitioning, and then you become the expert on the team. You know all the patients because you're rounding on them. You have a fund of knowledge. If they're coming from a different site, they may have forgotten how to use the EMR. So it's a tricky space because you have to recognize there's a hierarchy in medicine, and you don't want to overstep and start telling the chief of, well, this is how it's done here at Westwood. But you could potentially tell them, find ways to say this is how it's done in Westwood, because they may have forgotten. So just be mindful of that, and it's going to depend on the personality. So I can't give you some blanket statement as to how to go about navigating it. But typically the people who are closest to you in training, so the intern and the PGY2 may be appreciative of you assisting during that transition. as they try and figure out their own footing in this new space. So feel it out and get a sense of how you can be an ally as they, move from one setting to another.